بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. نحييكم بتحية عطرة. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, greetings. Today, alongside my colleague Abdullah bin Asfour, I'm your host, Faisal Zghabi, a current dental intern at King Saud bin Abdulaziz University for Health Sciences. And we are honored to be part of this scientific activity. On behalf of the Saudi Prosthodontic Society, I would like to welcome you all and thank you for your continuous interest in attending our online webinars. Any of who are inquiring about certificates of attendance, please note that only Saudi Prosthodontic Society members will receive the certificates through email. So if you would like to become a member, please visit our Twitter account @SaudiProsto and register through the designated registration link. As from now, we are glad to introduce our speaker tonight, Dr. Nasser Alqahtani. Dr. Nasser Alqahtani earned his bachelor's degree in dental surgery from King Khalid University. He earned his master's degree in prosthodontics from Indiana University in 2015, and he's a fellow of the Royal College of Dentists in Canada since 2015. He obtained a fellowship in Maxillofacial Prosthetic from Indiana University in 2016 and Implant fellowship from Loma Linda University in 2017. He is an associate fellow of the American Academy of Implant Dentistry and a currently consultant and an assistant professor at King Khalid University. Please, Dr. Nasser Alqahtani, if you can hear me, share your screen and the mic is yours.
بسم الله الرحمن الرحيم. إن شاء الله الصوت واضح. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. في البداية أحب أشكر الجمعية السعودية للسعادة الصينية على الدعوة وأشكرهم على الجهد المبذول ولا محدود اللي قاعد يقدمونه لنا. And special thanks to Dr. Mansour Asiri, the president of the Saudi Prosthodontic Society. My lectures and my presentation will talk about the immediate implant loading of fixed prostheses. And in the beginning, يعني لازم نكون كلنا احنا المسؤولين. الله يحمينا ويحمي بلادنا من الجائحة اللي قاعدة تصير ويرحم المتوفين على اثر هذه الجائحة. So at the beginning, we're going to talk about the always we were thinking about any evolution in dentistry, any updates, any improvement, any materials or procedures. It's always it has to be including two things: the patient desires and without. And the dentist with interest. Without patient desire, we cannot improve, or we won't have any interest to have an improved or any evolution. And without dentist interest, then with that the evolution will be slow or maybe won't exist. The immediate implant loading in general, it has a fast up desires those days, because there's a lot of patients, they don't want any removable prosthesis, and the most common complaint, they don't want to put the denture in the cup. And usually they have some claims that their grandsons or granddaughters, that they are usually afraid of seeing dentures in a cup. That one example. And some of them, they don't want to take it out and clean and put it back. It's kind of confidentiality for them. And so this is one, what immediate loading is in big demand those days. And we're thinking about it, why we want immediate loading, why immediate loading, why we don't do delayed or early loading. The patient perspective, usually we think about it, they look in one of those things, either aesthetic or function, psychological need or desires. They usually have one of those or two of those. But for the patient perspective, we only think about rehabilitation. And rehabilitation will all include all of this: aesthetic, function, psychology, and desires. So the patient perspective and the needs for immediate load is different than the dentist perspective. But in the general, our dentist perspective usually include all the patient's perspective and reasons. Okay, first of all, there's some terms we have to touch and talk about. Loading, usually when you do implant loading, it's mean any attaching a superstructure to an implant. So any attaching anything of prosthetic part on an implant body, that they call it loading. Loading doesn't mean it has to be under function, or doesn't mean it has to be under occlusion. So also function terms, we should be careful about using it, because function, it could be phonetic or occlusion functions. So function is not only a physical mean of load or occlusion contact. The function phonetic is a function. So we should be careful about using those, and that's what we're going to talk about later in this.
Sorry to disturb you, doctor. However, the sound is a bit jittery. So if there is anything you could fix, the sound is not very clear.
Okay. تسمعون الصوت الآن؟
Yes.
Okay. So the media loading, it has first appeared, and this term is 2002. And when they have appeared, that they usually they do the media loading in day one. That's mean the first day of implant placement. They do the loading, and what they call immediate loading at that time. And then the early loading from the day 2 to 3 months, and the confirmation loading from 3 to 6 months, and the delay loading more than 6 months. And then it got changed 1 year later, that immediate loading, it could happen in 48 hours after implant placement. And then it changed in 2006. And then they claimed that, okay, well, we can do the immediate loading, either function or non-function, I mean, under occlusion, no occlusion, after 27 hours after implant placement. Finally, immediate loading, they can be done within 1 week after implant placement. And so the term of immediate is not actually immediate after implant placement, but immediate it's mean within 1 week of implant placement. So while we have all of this change, while we have that fast change from like from 1 day, now it's 1 week. It's thanks to the scientific researchers, the gut change with the time. The implant body is not the same as before. It used to be smooth, less aggressive threads, now with taper implant, with self-tapping implant, and all of those change of the geometries, and the nanotopography of the surfaces, and the adding a micro topography, micro threads to the implant that increase the implant stability, increase the decrease the period of the healing, and make a faster healing of the implant, especially bone to implant contact. And this is why we have got changed from 1 day immediate loading to 1 week immediate loading, because of the geometry of the implant. Okay, so when do we can do where we can do the implant loading? We could do it for single tooth missing after implant placement, or we can do for extended partial dentures more than two implant missing tooth, or for completely dentures patients. And we're going to talk about every single of those criteria differently. At the beginning, we're going to talk about the single implant immediate loading. So there is a very good article that would combine with the big names of implant dentistry. And they put 10 keys of successful studies on single immediate implant loading in 2017. They put 10 criteria and keys if you want to have successful single immediate implants, especially for an aesthetic zone. So for first, the aesthetic risk assessment, and especially that we're talking about the thin, the thick biotype, the good outcome you can have it with a thick gingival biotype, and then with the high smile line, you might have high risk of high risk case, or with the low smile line, the good outcome we might have. CBCT scan is a mandatory for every single case of implant placement. 2D X-rays is not beneficial that much for the implant, especially for the planning, tomb planning. Trauma, minimum trauma, they decrease the heat, decrease the trauma to the bone, that we might have good outcome of the implant, especially middle loading, and also the amount of bone that we have, especially the apical to the implant and the buccal to the implant, and those walls is important to evaluate before do the implant placement or the immediate implant. Before, we used to use regular implant in anterior region for the single implant missing, or the single implant immediate loading. It's not any beneficial right now, because using narrow implants, we might have plenty of buccal bone, and we might have good predicted outcome later on. Buccal bone, 2 to 3 millimeter of gap between the implant and the buccal bone. We might have good outcome later on. Facial gingival graft, we're going to talk about this in detail, if we need it or not. And also, during immediate loading for the single implant, we can achieve a gingival contour right away and then we'll minimize the time needed for the whole treatment. So first of all, for single implant, we have common criteria to place the implant, and if we place the implant in an anterior region, it has to be placed away from the adjacent tooth 1.5, and then at least, this is the minimum. More would be better. And the apical position, or the vertical position of the implant, apical gingival, that it could be, it must be within more than 3 millimeter, 3 or more, 3 to 4 millimeter, that we can have good room and a space to control the gingival contour. We achieve good emergence profile. So when we have rhyme stability 3.5, and this is the article of Dr. Kemp, a very well-known article, and then no occlusion, I mean there is no functional occlusion at all. I mean eccentric or eccentric, and if the patient has no bar functional, or the bar function get controlled, like the paroxysm, we might have 100% success rate of implant, immediate implant, and immediate professionalization in the same time. So that's a good outcome if we follow those criteria. So would the gingival thickness help in hiding the abutment color? Okay, we'll talk about it. There is a very good article that we're talking about if the gingival thickness itself can influence the color or can hide the color of the abutment beneath it. Okay, well, what they did, they used different kind of abutment, titanium abutment, titanium and coated with porcelain, and zirconia by itself, and then zirconia abutment and coated with porcelain. And then this is animal study, and then what they did, they got the uh, thickness, or tissue thickness about 1.5, and then they found out if we have the gingival thickness 1.5, then they cannot hide any kind of color with the metal or zirconia. So it might be color differences between the tooth that it had replaced, the implant that had to be placed, and the contralateral or the adjacent tooth. So aesthetic outcome, it might that good, it might not be the good. If we have tissue thickness of 2 millimeter, then this is can hide as a zirconia or ceramic abutment only, but with the metal abutment, we cannot achieve this goal. So if we have a 3 millimeter, then definitely we might have hide the color of the shadow of the metal abutment and the zirconia crown. So our goal is to have a 2 millimeter or more, especially if you're going to do abutment zirconia, titanium abutment, then 3.3 millimeter is maybe what we need for. Clinical study, that's a very common clinical study that they did the extraction, and at the time of the extraction, they measured the thickness of the gingival thickness, and they got it about 1.15. And then they placed the implant, and over the time, with no connective tissue graft, they did not increase the thickness of the gingiva, and then they got 1.4 millimeter. That's mean if you have 1.4, there is no way to hide, or they hide the color differences of the abutment anyway. So if we have connective tissue, the average thickness we might have is 2.6, and at 2.6, yes, we can hide the color differences of the zirconia and improve the aesthetic outcome. But for this for titanium, we have it close, but not that much. Do we need a connective tissue graft? Yes, according to those studies, yes, especially for some cases, if the patient is highly aesthetic demand, if the patients have high smile line, or especially for patients with thin gingival biotype. Okay, to fabricate the professional or the temporary crown for implant, we have different methods and techniques. We have different materials, and this is the common. I got it from different articles. This is the common ways to fabricate professional or temporary implant prosthesis. For single prosthesis. Usually for the direct, the most common nowadays is the mix, which is direct and indirect. But if we're gonna do direct, then we have to need a wax up and the matrix or the jig. And the material used is very common, and we know it: PMMA, PIS gamma, or PIS acrylate. Usually we can use prefabricated crown or denture tooth. Or we can use the patient's own natural tooth, so we can still use it. For the indirect, that means it's all fully lab work, so we need immediate implant level impression at the same time of the implant placement, and then we can fabricate it within 1 to 2 days, and then it's all full laboratory work. And for direct and indirect, it's a combination of direct and indirect. So we need kind of lab work to do something what they call professional shells and jig placement jig. And then at the chair side, we use the shell to reline it or line it with some conventional material like the PMMA or PMA, sometimes with composite resin, and then we can achieve the immediate loading in this way. So the material we use for the indirect and the direct indirect combination way, we can have milling, and the milling material we have nowadays PMMA disc, we have PEEK, which is polyester ketone, and we have the bis acryl. For the uh, printed way, we have now the composite-based resin or the acrylic-based resin, and we have different companies and different printer nowadays to they can fabricate the temporary crowns. A conventional way in the lab, we could do the and PEMA, and then the PIS gamma and the PIS acryl, the conventional raw materials that we have in the clinic. So we can use it as direct and indirect way. So for the abutment, and the abutment, just to explain what is the abutment for some people they might not know, it's a connection between the prosthetic and the implant body of the fixture or the fixtures. So that's the connection between the prosthesis and the implant body. For the temporary, we have three types of temporary abutment. And if you look here, uh, this temporary abutment is only for temporary mean, even though it's titanium or whatever, it's only for temporary mean. That means it's we cannot use it for final goal or for final prosthesis. So we have titanium, we have PMMA, and we have PEEK. Titanium is very, very strong. The problem is aesthetic. We might see some of grayish color underneath the implant crown, and this is one of the disadvantages we might have. PMMA, very good aesthetic. The problem is very weak, it might fracture. So using it is kind of risky, especially for patients who, especially for a tooth that is what they call it loaded tooth, like the central and canine and the anterior region. I think PMA will be good for lateral incisor because they call it maxillary lateral incisor, because usually called as non-loaded tooth because it doesn't share any load during the extrusion or extrusion movement. PEEK is a new material for titanium abutment and is very good, very strong and aesthetically pleased. It's not as strong as the titanium, but it's strong enough to be used. But the problem with it is a little bit expensive. So if you need strong and aesthetic, cheaper abutment, we can use the titanium abutment, and we coat it with resin opaque or opaquer resin, and then we can achieve aesthetic and at the same time the strength goal. If you see here in this picture on the left, they use titanium abutment and timber crown, and you see the grayish color underneath the timber crown, and this is one of the disadvantages of the titanium abutment. If you look here, they use the PMMA abutment, and it got broken because of the weakness of the
Sorry, doctor, to interrupt you again. However, the sound is still not very clear. If you have a microphone that you could use, it would be perfect. Or you could just try to mute and then unmute yourself. It might work as well. If also you could close the video of yourself, it might also improve the sound. So whatever choice you have, you could do.
Okay, I unmuted. Is it okay now or
yeah,
not
yeah.
yet? Huh?
Can you try? Yes, it is a bit better. Can you try for follow slides, and we will tell you back again. Sorry to interrupt you.
No, that's fine. Maybe the connection is a problem. Okay, then let's go back to the lecture. Okay, so let's talk about this case. The patient has a broken tooth. This is a lateral incisor. It's not restorable anymore. If you think about crown lengthening, we might jeopardize the aesthetic outcome of the tooth. So we're thinking about implant, immediate implant placement after extraction, and immediate professionalization. So for this patient, we extract the tooth, automatically extraction, and we place the implant and we leave the gap. It's about 2 or more millimeter from the implant to the buccal bone. The connective tissue graft and this patient we used to improve the outcome because the patient was aesthetically demanding, very aesthetically demanding patient. And then after that, we did the immediate professionalization, and this is screw retain professional crown. Okay, the difference between the screw retain and cement retain for the final crown, it might not be that big differences, but for the immediate loaded implant, stick as much as you can with screw retain to avoid any cement using at this time of the immediate placement to avoid any healing disturbance of the implant. Okay, and this is the outcome after the immediate loading. This is another patient, and this is another methodology or method to use a temporary crown or to fabricate a temporary crown. So the patient has horizontal tooth fracture. The buccal bone was good. He has enough apical bone at the same time. We got the advantage of the tooth to use it for the temporary. So we decided to immediately automatically extract, and then immediately place the implant. And if you see here, the osteotomy, we left the gap about 2 millimeter to 3 millimeter buccal from the implant to the buccal bone. And then after implant placement, we use a placement jig or positioning jig to place the natural tooth, and we kind of hollow the tooth or make it like a shell. And then after we position it, to pick it up with composite material. And then after that, we adjust the tooth. So we need no contact whatsoever at the MIP or the central contact. And we should have no extrusion contact to avoid healing disturbance. And this is the final outcome, is very aesthetic outcome, especially if you use a tooth with no composite material stick on it. And then if you look here at the contour of the temporary crown underneath the gingiva, it has to be straight or concave to give the gingiva a thickness during the healing. And this is a recommendation that I always use. Concave temporary, it might make the gingiva thin at those areas. So we give a good space for the gingiva to heal and to increase the thickness if you do straight or concave temporary crown. So here, the before, this is when the patient presented at the day 1. And this is after, and if you see the smile is very, very aesthetic. So natural tooth, it's a very good aesthetic option to be used, especially for natural tooth that has no composite or is not broken that much. So for this patient, usually we avoid immediate implant loading for posterior area. It's not because it's not there's no evidence or it might not work. No, it's because the need or the beneficial for that is less than the anterior region. But for this patient, he's a very aesthetically demand. He don't want he wanted as possible to do immediate loading. We agree. She needs 2 implants, which is the premolar, first premolar, and first molar. So we agreed to do the immediate loading for the first premolar, but we kind of not accept the idea of doing the immediate loading for the posterior molar, for the molar implant, because it's going to be high risk of failure in that area. So and for the way we use it, we also, the patient was demanding to have zirconium implant, and as a zirconium implant, we agree also to do zirconium implant for premolar, but not for the molar. So we printed a surgical guide to have a fully guided surgery, and this is minimize the time, minimize also the uh, uh, the the out the any problem that might happen. So the printed surgical guide or the fully guided surgery, it's a very good option. The problem is a little bit high price, but price a little bit, but it's very good option and precise as much as you think, but you need just training for to fabricate and to use it. So in this patient, what we do, we place flapless implants in premolar and the molar, and then if you see here, this is the zirconium implant, and it's one piece implant. What it means that abutment, the implant body, it's all fused together, so it's all one piece implant, and it's usually a cemented type of implant. So what we're gonna do is cement the crown. So in this way, we use a jig or matrix, and it's a conventional way, and we just fill it with the bisgamma uh, temporary material, and then after that we cement it with temporary cement. We have to make it out of occlusion, and there is no extrusion or any lateral movement contact whatsoever to minimize the risk of failure. So can we do immediate implant loading for extended partial edentulous site? Okay, there is a controversial articles. There is a lot of argument about this, but we'll show you one case and we're going to talk about it. If you see here, the patient has all the bridge is broken. The tooth is also broken. After we evaluated the tooth, it's not restorable anymore. One of the tooth has a vertical fracture, so it's not restorable. And the other one needs crown lengthening and might jeopardize aesthetic more and more. And then if you look here, we did a surgical guide in the same time. We can use it as a temporary crown later on. And this is a milled surgical guide and temporary, and it's PMMA material. After that, after extraction, we check the surgical guide, the temporary PMMA, and it's supported by the adjacent tooth, okay? And then we place the implant according to the position of the surgical guide, and then after that, we'll pick up. So this is direct, indirect way of doing temporary prosthesis. And if we direct after the pickup we use a temporary metal temporary abutment, stronger, even though it's not aesthetic, but it's stronger. And if you see, the aesthetic outcome is very good. But the problem, there is no sufficient evidence to support partially extended partially edentulous implant. We're talking about temporary or immediate loading for bridges, implant bridges, especially with two implants. There is no sufficient evidence, and there is a lot of argument about it, especially for the anterior maxilla. There is very low evidence for this. So we should be do this for caution. And if anybody want to do it, only the experienced dentist or experienced implantologist, they can do it. And at the same time, for the posterior, there is no benefit to do it's for the posterior implant a bridge or a mid loading bridge. The evidence is good, but there is no beneficial of doing it. There is no aesthetic beneficial, and there is no function because the patient been doing this for a long time. So we usually avoid any kind of immediate loading for extended edentulous site as much as we can. So for immediate implant loading for full arch prosthesis, And there is a high risk of doing it and then of failure for this. But in general, the success rate for those kind of procedure is very high, uh, especially if you achieve some criteria. We're going to talk about it. So implant failure usually happen more with the prosthesis patients because, you know, if you're going to do full arch immediate loading, it has to be under function because there is no way I make it out of occlusion. It has to go under occlusion. It has to go through the occlusion. Unless the patient has opposing denture, then yes, the occlusion is has less force, or maybe they cannot use the opposing. They might ask them not to use the opposing denture. But usually the patient, you might have upper and lower immediate loading at the same time, or they have opposing natural tooth. So the paroxysm usually have 25%, the highest implant failures. And then if the patient has opposing implant fixed prosthesis, you might have about 25% of implant failure. And because the patient has less perception and less feeling of the implant movement or implant in the bone. I mean, the micromotion of the implant and feeling of it during the function is going to be very less than if the patient has opposing natural dentition. So a fresh extended socket, yes, that it could be a risk. And the diameter less than 3.5, we're talking about implant less because the surface area is less, the bone to implant contact is less, and then the patient might, the implant might have higher, more than, of higher force, the more than its limits, so it might fail. Opposing natural dentition, yes, and then the sinus graft, any grafting material or sinus implant and loaded by prosthesis, it might have failure as well. So for the prosthetic failure, usually the misfit is the most common prosthetic failure during the immediate loading, and the acrylicism-based fracture is the next most common. But for the acrylic resin-based fracture, it's easy to do direct repair in the patient direct, unless the patient has fracture that continues discontinued fracture of the framework or the resin. Broken denture tooth, this is very common also, especially if the fabrication is not that good, if the contact between or the chemical bonding between the denture tooth and the resin base is inadequate. So let's see that the patient has upper denture and the lower should be living like this for a long time. And after evaluation of the ridge and the bone, the patient has very minimum bone in the posterior area. The patient is happy with the upper denture. She doesn't want any implant of a denture or fixed implant prosthesis. What she wants is lower, because she has RPD before, lower mandible RPD, and she refused to have any kind of removable prosthesis in the mandible. So after evaluation, she has no inadequate bone in the posterior region. So it's kind of impossible to place implant beyond the inferior, the mental foramen. So after evaluation, we kind of have we have 3 digital models, and then we printed the model. It's like bone models. And then after evaluation, we kind of combine the digital work with lab work. So in this way, we kind of fabricate a new denture for upper and lower. And it's like immediate denture for the lower and new denture in the upper. After that, we mount the bone model according to this. And then we kind of simulate the surgery. So that we plan to do it in the patient mouth, we simulate it in the lab. So we did the extraction, and then we kind of do bone reduction. And then after that, we kind of place the implant, like to simulate the drilling and the implant placement. And for this, we decided to do all-on-4. All-on-4 concept is when we have 4 implants, the anterior 2 implants straight and the posterior 2 implants tilted. It's about 35 degrees or more. So at the time, so what we did is how we fabricate a bone reduction guide to see how much we can deduct of them from the bone. And then we did initial implant surgical guide, just initial, not fully guided surgery, but initial. And this is all handmade on a printed model. So this time with the surgery, we extract the tooth, then we use the surgical reduction guide, and then we place the implant. No, we use the surgical guide initially, and then I don't know if you see that, but if you see the implant, the drilling and the alignment we checked, and then we place the implant. After that, we use what they call it multi-unit abutment, and then after that we use a healing abutment, and then she is ready for immediate loading. So we use the denture, we fabricate the immediate denture, and we marked the area that it has to be hollowed, and then they make a hole to pick up the temporary abutment. And after we pick it up, we take it to the lab, and then we finalize and finish the prosthesis. And then after we finish it, the anterior surface of the prosthesis, or the tissue surface, it has to be convex as much as you can. Concave is going to be very difficult for the patient to clean. And then for this patient, we give her the hygienic space more than 2 millimeter to be able to clean underneath it, because it's fixed. So the patient has to clean the area beneath the prosthesis. So we give them more than 2 millimeter. And this is the guideline. We know all that the hygienic space, it has to be more than or equal to 2 millimeter. And this is the patient walk away from the clinic with upper new denture and lower fixed, immediate loaded, complete prosthesis. The other patient that has terminal dentition, the patient has very, very bad oral hygiene. After that, the patient wants something fixed, and he used to scared of dentists for a long, long time, and then he decided that because he has the money that he wanted to do it, but he doesn't want any complete or removable prosthesis. So after evaluation, he needs full mouth extractions. So what we did to make sure that he will follow our instructions, so we decided to do a complete denture first for him, and we'll see if he can control the hygiene and follow our instruction. If so, then we might do fixed prosthesis for him. So we did immediate denture, and then after that, this is the picture after 2 months, about 2 months, and then the patient was cleaning very well the prosthesis. He followed our instruction well. Then we decided to do fixed prosthesis. So what we decided to do immediate implant and implant placement in a healed site, and then immediate loading of the prosthesis at the same time. So for this patient, we did something what we call it dual scan procedures. So we use a zirconia marker or pearl. This zirconia marker that it can be used for dual scan. So if you see, we take the CT scan with the denture inside the patient mouth, and then we take the CT scan of denture itself, and that's what we call it dual scan technique. And after that, we digitalize the work of fabricating the surgical guide. If you look here, this is the bone model, and this is virtual bone model, and this digital bone model. And then this is the maxillary or the mandibular scan of the denture. And what we did is superimpose the denture on the bone. After that, we check the position of the denture and the bone. And then after that, we simulate the bone reduction and the implant placement virtually. After that, we fabricate the bone reduction guide virtually, and then we did overlay surgical guide, implant placement guide on top of the bone reduction guide. And this is after printing. This is a printed model just to show, but then this is the bone reduction model, and this is the bone reduction model. On top of it is the surgical guide, and this is fully surgical guide. For the maxilla, it's kind of different, that we did only initial surgical guide and initial just to know where we place implant. The reason is because at the CT scan, after the CT scan, the bone quality was not that good in the CT scan, so it's very hard to fabricate a surgical guide, bony supported surgical guide for this patient. So this is still another way of doing it. So after superimpose the denture, we did the bone reduction, and for the restorative, to achieve the restorative space for the prosthesis. And after that, we make a hole to mark the area where we do the bone reduction. And then after that, we make the holes or mark the holes for the implant, initial implant placement, or the initial implant guide. And this is the guide after printing. If you look here, there's holes in the buccal. This is to help us to know how much we're gonna reduce the bone. And this is the guide for the implant, itself. So the day of the surgery, we did the upper and the lower in the same time. If you look here, so we use for the mandible the surgical reduction guide, and then after reduction we use the implant surgical guide, which is fully guided surgery. And if you look here, this is the implant placement, and we use the multi-unit abutment. And then after that, we pick up the temporary abutment, and then we finish it at the lab. If you see here, this is convex. It should be very smooth. And after that, we place the lower immediate loaded complete prosthesis. And we make a surgical, or I'm sorry, hygienic space about 2 millimeters underneath the prosthesis. Okay, this is for the maxilla. We use the maxillary surgical guide in the same time. We use the fixation pins, and after we use the fixation pins, we mark the bone, so we know how much we're gonna reduce the bone, and then we use piezo instruments, surgical electrical piezo instruments, so to deduct the bone. So we mark it, and then we remove the bone. After that, we place the implant. After implant placement, we use just a putty index to know where we're gonna cut or make a hole to pick up the temporary abutment. After making a hole, we pick up the temporary abutment directly from the patient mouth, and then we take it out to the lab. If you see here, it's kind of straight a little bit. Better to have a concave just to increase the hygienic quality as much as we can. And this is the outcome. And if you remember, the patient has very unpleasant aesthetically tooth, and now he is walking out from the clinic with upper and lower immediate loaded fixed prostheses. This is the last case I'm going to talk about. The patient has terminal indentation of the maxillary arch. After taking out all of those bridges, then we found out there's only one tooth that is restorable and the other is not. So what we did is to do full upper arch fixed prosthesis, and we decided to do immediate loading at the same time. So we did wax up for the upper to improve the aesthetic, and then after that we scan the wax up, and then after we scanning the wax up, we fabricate the maxillary surgical guide digitally, and then we print it. And this is, I'm sorry, this is milled. And then after that, we fabricate a PMMA surgical guide and PMMA temporary prosthesis. and this one-piece PMA milled prosthesis. So after we place in the implant, we pick up the prosthesis directly at the patient mouth, and then we finish it up. And this is what we decide to do all-on-4 implant concept. So this is the day one, and this is the implant. This is the static outcome after that. The patient it has to be on occlusion. There is no way we have it out of occlusion. The problem here that he has very steep occlusion on the left side, so we couldn't make it on occlusion. So take home message: for single implant immediate loading, there should no occlusion whatsoever. The contour underneath the gingiva should be under contour, or at least straight contour. Screw retain temporary immediate loaded as much as we can to minimize the complication. Metal temporary abutment as much because of the strength, and then as much as we can. If we're going to do immediate loading, it has to be more than 20 Newton per centimeter. I'm talking about the primary stability. For the full arch immediate loading, guided surgery as possible to minimize the time, to minimize the complications, and to have a precise implant positions, and then even contact as much to distribute the force, and then minimal cantilever as much as we can, and good hygiene space, more than 2 millimeter will be fine. Screw retain as much as we can, because we can retrieve it anytime, clean it, put it back, better than cement retain. Metal abutment to make sure that no dilemma during and drama during the healing. And then diameter of the implant should be more than 3.5 as much as you can to minimize the risk of implant failure. And for primary stability of the implant, it should be more than 30 Newton per centimeter. For the immediate loading, for the extended partial implant immediate loading, when I'm talking about the bridge with 2 implant, we should be very, very careful of doing it. We should follow the extreme caution guidelines for those kind of patients, for those kind of cases. If we can not to do it, then it's okay, because especially if the posterior area, because there is no beneficials doing it during the healing time. For the anterior, if we're gonna do it, we should be very, very careful. This is the references. Each one want this. This is the references, the barcode, if you want it. And special thanks to Dr. James Lozada and for helping me on those cases, and also for Brian Goodacre for helping me in the digital workflow for most of those cases. Okay, well, thank you so much.
Thank you very much for your informative and amazing presentation, Doctor. If you may stop sharing your screen so we can share the question with the audience.
Okay, stop sharing the screen. Okay.
As from now, Doctor, you may answer the questions from the audience in the Q&A section. Please click on answer live for any question you would like to answer.
Okay, so wow, there's a lot of question here. So okay. Okay, one of the questions is why do we tilt the implant in all-on-4 concept? Very good question. Okay. Most of the time, we'll talk about mandible. If we're gonna place the implant, sometime we might not have good vertical bone bone height in the posterior to the mental foramen. So The problem is we might have very high, big or very long cantilever if we place the implant intraforaminal straight. So for the anterior, we place it straight. The anterior, we kind of tilt it to kind of minimize the cantilever and then minimize the complication later on. So it's kind of to increase what they call it the EP spread, or the EB distance or EB spread, which is the distance between, just briefly, is the distance between the anterior implants and the posterior implant. Tilting the implant to increase the EB spread and when we minimize the cantilever as much as we can. Okay. Okay, there's a very good question here. What type of occlusal scheme you did provide for the patient with the full mouth immediate loading? Okay, as much as we can for those kind of patients, we do group function. And there is, by the way, there is a lot of argument about it, but I think group function will be good for the patient. Balanced occlusion might be harmful, or it's impossible, kind of possible to do it in those kind of patients. But the group function is easier and will disturb the force better than the canine guides. Canine guides is good, but the problem during those kind of surgery, it's very difficult to control it. You might have a steep canine guidance, it might broke. So I think group function, and this is what I do for full arch prosthesis, immediate loading. What is the recommended hygienic space for maxillary arch prosthesis? For the immediate loaded prosthesis, immediate loading, 2 or more, and more is better, okay? If we can have 3 or 4 is fine. For the fine prosthesis, 1 to 2 millimeter is enough, okay? Because during the healing, the patient need to clean underneath the prosthesis during the healing, not to avoid any complication as much as we can. Okay. I didn't make it live. Okay. Do you recommend tissue graft for every single implant, immediate and professional? For single, this is most of the authors they recommend it, and the reason is what I talked about it, is to increase the aesthetic outcome. But if the patient is low smile line, he's non-aesthetically demand, and he has already a thick biotype tissue, then you might not do it. But to increase the aesthetic outcome, we could do it. We can consider it for all of the cases. That's it. Well, one more question.
You can answer more.
Okay. Okay. Very good question here. One make digital guides, sometimes it doesn't fit. There is a lot of factors. First of all, usually if we're gonna do it to tissue supported surgical guide, and this is usually we do it for flapless prosthesis, then usually it might fit. It will fit, and the preciseness of the tissue supported, soft tissue support surgical guide is higher than the bone supported surgical guide. For the bone surgical guides, because when we do the CT scan, the quality, even though it's high, or some device is very high, but it might not be very good after you might lose some data during the transformation of the data from computer to computer, or at the same time, the quality, it might not be that good. When we fabricate the bone reduction guide, then after we're missing some part of the bone digitally, it might have some negative like increase of the surgical guide at that spot. When we use it at the patient mouth, you're not fit. So bone reduction guide, bone supported surgical guide is less precise than tissue supported surgical guide. Okay. That would change your mind regarding connective tissue graft. If I'm going to use zirconium or titanium abutment, that would change your mind regarding the connective tissue graft. Yes, but sometimes you don't know what you're going to use, either titanium or zirconium. So it's better to use connective tissue graft if the patient is highly aesthetic demand. So for if we are sure 100% that we're going to do the zirconia, which is very difficult to sure that 100% we're going to use zirconia, then 2 millimeter is fine of gingival thickness. So we might not need the connective tissue graft if the patient is non-aesthetical demand. But for the titanium abutment, I think is very, very, very mandatory for most of the patients. Okay, well, I think we reached the end.
Thank you very much, Doctor, and thanks, ladies and gentlemen, for your attendance. And please stay tuned for tomorrow's lecture by Mr. Farraj, titled When Wax is Gold. That ought to be interesting. That was your host, Faisal Azghabi. Stay safe, stay home. Good night and goodbye.